to do that. Recording is now in progress. And I believe that covers it. If I've forgotten anything, then Tim will probably remind me. I'll turn it over to Tim to do a little bit more of walking through what we're going to discuss in today's meeting, and then we will take it from there. Tim?
Okay, great. Thank you. And thank you all for joining us again. I see a lot of faces that joined us in month number 1. This is the second meeting. And again, we're hoping that we're able to conclude the majority of this work group's work by the Thanksgiving is our date. So this is a third of the way through with 4 meetings left. By way of a reminder, the focus of this group is really on 2 levels of care. One is entirely brand new, and one would also be, we've had some experience in Connecticut with it, but the first one is the Behavioral Health Urgent Care Center.
Hold on, Tim, hold on. This is value-based purchasing.
Oops, I got the wrong one out. Sorry, guys.
All right, back it up. We'll do that tomorrow.
Back it up. Sorry, that's right. Yes, so the value-based purchasing, sorry, did a retake there.
I'm right there with you right now.
Got the wrong. Yeah, sorry. Jeff and I have been planning all these different activities. So yeah, so we wanted to be able to start to take some feedback.
If you could put your phone on mute, that would be great. We're getting some feedback. Thanks. All right, I think we got everybody on mute. Go ahead.
Got it. All right. So apologies for jumping off for the wrong agenda item on that. Yes, so we are looking to move off of what last month's presentation where we gave an overview of the value-based purchasing. And there were, again, 2 parts of this work group. We wanted to start our conversations off the general overview of value-based purchasing, and then also at some point be able to talk about measurement-based care platforms. So those were the 2 areas of focus in this work group. Specifically, we started with some overviews of some activities that are occurring in the state of Connecticut already, where value-based purchasing has started to already take root. We certainly have seen a lot of it in the primary care world, and we'll continue to see more of it introduced into the mental health, behavioral health world. So we felt like the framework that was outlined last month would be the way to jump in and continue the conversation. So we really, again, want to have the opportunity to have people give as much feedback and information from your own areas of expertise. Areas of questions or comments are really welcomed. And then we'll continue to kind of move forward in the general conversation around value-based purchasing. And really, I think what we did lay the foundation last time is that the quality of care is often in the current system under the fee-for-service process is that often your funder will collect data from providers. The funder will collect data from the providers that are reported and then give that data back to the provider. And then there'll be often conversations around the quality as a result of that data and what's occurring. And that often will occur within the context of weeks to months, sometimes months and sometimes longer after the fact, if you will. And really what value-based purchasing in terms of the cultural shift is having data much more rapidly and readily available so that anyone providing the service is getting much more information back on the quality of a service being delivered and the experience of the individual and family person receiving services. And so that's really where we're continue to focus kind of the cultural shift into value-based purchasing. And so that those providing services are able to be more responsive to kids and families' needs much more rapidly.
Can I ask a quick question? I'm sorry. This is Cheryl Escarbo from Connecticut Children's. I typed a question into the chat, but if we could just get clarity, it will help me guide me through the thinking for the rest of the discussion. I've seen in references for this particular meeting, value-based purchasing and value-based payment used, each of which has a kind of a different aspect to it. So in this meeting today, we're seeing value-based purchasing, which makes me think that the perspective is that of the employer or consumer, as opposed to value-based payment, which would be really focused on engaging providers to provide value-based care, moving the reimbursement model to value-based reimbursement. So just for the purposes of the rest of the discussion, I just want to be clear on what aspect we're looking at.
Yeah, and apologies for that, and agree and understand. So I believe our interest is really on both. I think we're often assuming that we're talking from the funder to the provider person providing the services, but we also don't want to underestimate the user experience. And so I think that's probably where some of that may come from. But really, at this point, we're focused largely on the conversation around shifting kind of that culture again, to use the information that comes in much more rapidly in terms of the data that we collect. So I think that would be my answer. Jeff, I don't know if you wanted to respond to that.
Yeah, based on the way that you laid those out, Cheryl, I would say we're more in the value-based payment arena, meaning like changing the way that behavioral health is being paid for from a fee-for-service model to more of a value-based model, if that helps clarify things.
Thank you very much, both of you.
But I'll reinforce Tim's point as well, that as we do that work, we're thinking about it not just from the payer's perspective or from the provider's perspective, but also making sure we're taking the consumer experience or the family's experience into consideration.
All right. And then lastly, as we mentioned last time, we do, we want the conversation as we rolled out this work group was to define it as an operational work group, and that being what would be the best expertise and best evidence about implementation in Connecticut, and not, making a decision about whether we do or whether we don't. So that was what the plan has already called for, and moving in the direction of, implementation. And again, implementation is happening already in multiple projects. So I think that's in general where we're headed, and we would like to be able to formulate formal recommendations to DCF, to each of the commissioners of all the state departments, the DCF leadership, and the implementation advisory board membership and tri-chairs. So there's a multi-directional reporting structure regarding what we kind of come up with a series of recommendations for. So with that, I will then turn it back over to Jeff and Eric for the next.
So let's use a little bit of time that we have at the beginning of this meeting to address a couple of level setting questions. Gary Steck just submitted one through the chat box as well. So let's address that. We will at some point turn it over to Eric to start talking through a couple of elements of and getting people's input around elements of a value-based system. But Gary's question has to do with whether the intent would be to roll state what has been payment in the form of contracts, for example, the children's OPCC grants. Would that be folded in some way into a new value-based payment mechanism? Or I suppose the alternative, Gary, would be, is it the state's intent to continue to provide grant-funded support in addition to a new value-based reimbursement method? I've got Gary shaking his head, so I think I'm on the right track. So Tim, you want to address that one?
Sure. So a great question. And again, I think a couple of points there. One is, so with things like the 1115 waiver and other activities like the integrated care for kids in New Haven and others, there's some basic requirements as we raise levels of competency and levels of care, if you will, or raise the degree of treatment in these different environments, that some of those are already going to be coming and are on the way. And as that happens, I think some of that is to be decided and to be determined, but there are parts of it that will be required in some of these concrete activities. And as those go forward, I think that all the state departments, or at least again on the children's under the partnership, there'll be those will be implemented, and then we'll see how to consider adding others. But at this point, I know of no plan to do that quickly or rapidly. And I think that there is some plans and some thinking that there's some base contract grant work would need to continue to occur. So I think that's really from what we've seen so far. But I think a lot of that is to kind of evolve.
Okay, Bill, I see that you're off mute if you want to add to that, but I'll also note that Heather Gates has asked also whether as part of this approach, there will be an effort to create a payment system that reimburse at cost to the providers. So Bill, do you want anything to add there?
Sure, and I apologize for being late. I was in a public meeting that I was just finishing up. So good afternoon, everyone. So I think that is our intention. I mean, that is our goal, is to try to structure these value-based payment models in a way that aligns incentives to make sure providers are equipped with the tools necessary to deliver, kind of high value services, whether it's evidence-based or high value services to our most acute population. So we're trying to kind of align a lot of different principles. To Heather's direct question, that would be our intention, is that we understand that the rate structure has not kept up with the cost structure. So there may need to be a kind of a rebase and then develop the value-based reimbursement model on top of a new fee-for-service model. We're still trying to figure out kind of the very end kind of point of and how to pay for that. I think it is very likely that there'll be kind of a stepwise process that we build on top of an existing fee-for-service model. And again, maybe need to rebase the existing fee-for-service and then build the value based on top of that, maybe a pay for reporting period where for slightly enhanced rates, you're giving us information that leads us to ultimately the point of maybe a different payment system. And I'm just going to acknowledge that we haven't buttoned down, whether it's some sort of PMPM or case rate or something like that. So totally open for discussion on kind of the very end type model payment. But along the way, we think we have some ideas of how to get there, no matter what that end payment is. And that would be a step process to help move providers from where they are today and get them to a point where there's better capacity, better access, and also aligning our ASO responsibilities related to member attribution to the provider. So then we can start collecting outcome data by provider, maybe stratify the members, not just by age, but by acuity. So we're not disincentivizing you to take those that need our help the most. So trying to factor all of those elements into a value-based payment program where the system really is advancing to a more sophisticated place where we're tracking outcomes, getting better outcomes, and we're paying providers for those better outcomes. So that's kind of the guiding principles that we are using. And I think I've said this in other public meetings, and it's worth saying. I think some people think when they hear value-based reimbursement, they immediately jump to downside risk. I don't think our system is ready for downside risk. I think we are many years away from downside risk, and we have a ton of work to do before we would even have that conversation. So that I'll just say that is not part of our equation right now. It's mostly about building capacity and kind of the building blocks of better outcomes for our members, and yes, paying for better outcomes.
Great, thank you, Bill. Finally, and this will be our kind of last level setter, and then we'll kind of jump into this worksheet. But Gary is asking a follow-up question about the requirements of being in an OPC or an enhanced care clinic, and just contemplating the complexities of overlaying all of that without some infrastructure or resources provided to the providers to be able to implement value-based. And I guess I will kick off a response to that by saying, at least what I'm hearing in part from Tim and Bill, is that this would be implemented in some kind of glide path strategy, that the providers wouldn't be exposed to downside risk initially. But to your point, Gary, and probably others are thinking this as well, what do Tim and Bill or others, what do you think about investing in provider infrastructure to be able to fully participate in a value-based strategy?
Jeff, if I could just kind of maybe answer that question, at least from my perspective, and kind of reaffirm and say this out loud again, we don't think that providers are potentially in the position even to get into glide path under the current payment model, right? So if we start asking for reports on client satisfaction, what are the evidence-based practices you're using? What's your diversity, equity, inclusion plan? What's your data on access by race, ethnicity, age? What's your satisfaction by race, ethnicity, age? So all of that, and those are just kind of some things that we're talking about. Are you using the class standards? Are you participating in zero suicide initiative? So we don't think that we can ask them to even step foot into the glide path phase without some help financially.
Heather, you have your hand up. Another question.
Yeah, just a comment, a request really. As we have these conversations, if we could talk about building on existing competency, as opposed to what I think is often implied in these documents, that what we're doing now has no value. And for those of us who have just survived the last year and a half delivering services and continuing to deliver services and seeing people face to face, that's actually rather insulting as we start this process. So if we could try and change some of the terminology to be more respectful of the people delivering the services, I would greatly appreciate it.
So Heather, if I have said something to indicate that you're not providing value, I would like somebody to tell me that right now, because that was never my intent. And if they came across that way, that was certainly not my intention.
It's not in what you've talked about, Bill. It's in some of the verbiage that comes out in the documents, and the implications that, it's really when there's a link between payment and outcomes and use of the word value in that is implying that what the services being delivered currently are not of value to the people receiving them. So and this is from, I read all these documents carefully. I'm on the National Council for Behavioral Health Board of Directors. I'm well informed about it, and uniformly in the industry, when people are talking about value-based payment, there's an implication that what is there currently is not getting the job done properly. And so it's really just a request. It's a respectful request to ask that we're careful with our language in relationship to the work that is currently being done, in this case, on behalf of children and families, and at a time when it's just been particularly difficult to deliver those services.
Okay, point noted. I will just share with you that within our state agency meetings, looking at some material related to value-based reimbursement, we have acknowledged that there may be some providers that are going to fly through these steps, right? So whether it's pay for performance or once we have an attribution methodology and start collecting outcome data, you may already be exceeding the outcome data. And so we've acknowledged that in our own kind of internal meetings that we could have some providers, move through the steps very quickly based on your current operation and outcomes. That's very likely, and it's probably going to be all over the map. So we appreciate that comment.
Could I add, I just want to say from all the internal meetings that I've been a part of, particularly on a couple of projects, and 1115 substance use waiver being one of them, was what I hear more than anything from the state partners and funders is how appreciative of the work being done right now on the rates being paid has been, that it's really been come up multiple times, and how remarkable some of the work is based on what people are getting for the services. So I certainly would echo that there's never been in my experience a conversation about the work being done not having value. So I certainly also will pay attention to narrative and vocabulary as much as we can. So thank you for sharing that, Heather.
Yeah, I appreciate it too. And I know it's all over the things that I've been disseminating in that notes. I think I completely concur. As we get, I don't know what we would use, Heather, as an alternative. I'm thinking about value-based as more of an industry term as opposed to communicating anything about current service delivery. But so if we don't figure it out during today's meeting, we will convene and talk about use of terminology and come up with something that addresses your concerns so that we can make sure we're doing that in future meetings. So I'm going to level set. Well, let me just kind of provide a little bit of context, and then I'm going to turn it over to Eric Schwartz to facilitate the next piece. But if you remember from our last meeting, which was about a month ago, we had a presentation from Bill Halsey, who talked about some of the examples of this work going on in the state already. That included a brief overview of the 1115 waiver. I think a little bit about the Integrated Care for Kids initiative that includes an alternative payment methodology. And actually, maybe there's a good terminology. Alternative payment methodology might be a good replacement. And then from there, we heard from Bert Plant at Beacon Health Options. And one of the things that Bert offered to us in his presentation was the need to align this strategy along multiple domains. And those, the first three that he mentioned is where I thought we could spend some time today talking about getting input from all of you. What are the goals of an alternative payment approach? What are the strategies that Connecticut should be employing in such an approach? And then what are some of the metrics that we can think of that can help us determine whether we're getting towards those goals and outcomes that we've identified? So a lot of this is going to be generative thinking. It's going to be a bit of a brainstorming session, but we want to be able to document your ideas and your input and your thoughts and your suggestions so that we can continue to kind of build this. So with that overview being provided, let me just hand it over to Eric Schwartz, and he's going to walk us through. Eric, you can either bring up that worksheet and screen share it, or I can do that, but I'll let you facilitate the conversation, and I'll be back behind the scenes taking a few notes.
Okay, Jeff, if you would share it, that would be great. So thank you all. Thank you, Tim. Thank you, Jeff, for letting me do this and being willing to let me do this. Obviously, for me, kind of facilitating this discussion around some of these metrics and the goals and strategies is a sort of a unique position because I'm not from Connecticut. I don't have a lot of experience in Connecticut, but I have had experience with both managed care and value-based payments and value-based models in Pennsylvania. And so I do have a little bit of a background. I'm certainly not an expert, and certainly from a provider perspective, because that's all I've ever been as a provider. And so in thinking about facilitating this, I certainly have my own kind of experiences to hopefully bring to the plate that have been both positive and sometimes problematic with value-based payment methodologies, as well as, because they're in Pennsylvania, they're mixed in with managed care, because Pennsylvania has a fully managed Medicaid mental health system, behavioral health system. So with that sort of as a backdrop, and you all have obviously a lot more experience in Connecticut than I do, the first kind of area that we wanted to talk about, and that we did talk about, were kind of the goals of value-based payments. And so, as you can see below in the question prompts, what are some of the things that are the goal? What are some of the goals of value-based behavioral health care for children? And in that context, one of the things I'll say is in being part of a system that had some value-based, it was all pay for performance kinds of models. There's really very little good data that I'm aware of around value-based payment models for kids. A lot of the work has been done in the adult system, but the work in the kid system across a number of different is much less robust. And so that's part of the challenge, right? Is developing a system for kids that doesn't have a lot of models to work from, and how it applies to kids and families. And one of the things I saw in this first thing is that's not listed around the goals is, one of the goals is, of course, assigning risk. There's always a goal of assigning risk in value-based models. And so that wasn't added, that wasn't on this list. And it's one of the things I thought of that should be kind of part of the list is assigning risk. Is it a small risk? And especially for the provider, is it a small risk, a medium risk, a large risk? And each of the value-based payment models have different levels of risk for providers. So as we sort of go through this, if there are comments, that people want to make about the goals, we should make them, and then Jeff can put them into the work group recommendations. So I just open it up for additional feedback and comments around the goals area.
You want me to? I have two comments.
Yeah.
This is
Oh,
Heather.
go ahead. Sorry.
Under G, reduce the overall cost of care. But a question, is it reduce the overall cost of just behavioral health care, or of the total care inclusive of all conditions? So just more definition to what does that particular bullet mean? And then I would add in this section, establishing adequate provider reimbursement or adequate rates.
Yeah, I think that's going to be especially critical, as well as, and how do we integrate behavioral health with primary care? And that goes back to the rate structure as well. I mean, we all have lofty ambitions of providing better and more behavioral health, but if you can't get the provider complement based on the very subpar reimbursement rates, the rest of these goals will never come to fruition.
I think the other, so from my experience in one of my programs that I oversaw that was a pay for performance model, one of the challenges was that that when you do a pay for performance and you do a holdback, so you get a certain amount of dollars, and then there's a holdback for quality measures. The issue is that initial rate high enough to support the services provided? If you have a low rate already, and then you hold back money, it makes it very challenging for the system and for the provider to provide and meet the metrics. So the basic rate has to be high enough so that you're not taking away from something that's already too low.
Agreed. One of the other measures that we've been paying attention to is follow-up after hospitalization. And I would just kind of bucket that under maybe a guiding principle that I wanted to test with this group too, that I probably neglected to share. I mean, one of the things that we've been thinking about is how do we increase the ability for an outpatient provider to take full responsibility and accountability for a child, no matter what level of care they are in. So, and what's the payment mechanism? So how do we incentivize both the hospital and the outpatient provider to allow that child to move through that system of care efficiently as possible and as safely as possible, and incentivize both the hospital and the outpatient provider to take, especially the outpatient provider, because we think that's where we want kids to be, right? That's a lower level of care, but how do we increase accountability, financially, either through a care coordination payment or a PMPM payment, so they are ongoing accountable for that child's well-being, right? And how do we, so they don't close the case if a child goes into the hospital or goes into a PRTF, they keep that case open, they check in, and they are motivated and incentivized to help that child move through the system back to outpatient services. That is kind of the model that we would really like to explore, that no matter where that child is, that outpatient provider says, I got that child, we're going to follow up with that child, we're going to help that child and family move through the system, whether it's PRTF, whether it's out of state, in state, we're going to work with that family to get that child back into our outpatient program.
Bill, I think you're hitting the nail on the head. That's such an important part of this. And I frankly am having a hard time wrapping my head around how we will get there without more vertically integrated systems where you can control both the hospital and the outpatient side and work those things through. But I think that these are the conversations that that we need to have, and we have to be careful not to create, if we're going to do like a pay for performance system or a holdback, I think selecting what that is going to be tricky, because we all see kind of well-intentioned plans ending up with creating a perverse incentive, or for instance, hospitals are we already are monitoring a length of stay and readmission and all of those kinds of things. But if you're going to then if it's going to impact payment on things that might be outside of our control, that's an issue. And if I were an outpatient provider, I'd be worried about the hospital discharging folks too quickly who really are not ready to be discharged. And there's got to be a way for us, for providers to work together in a team and have some shared skin in the game for that. I don't know how to do that, but I think the question you're asking is perfect.
I agree with you, and again, I don't have all the answers, but I just use the follow-up after hospitalization, right? So that that's a clearly defined measure, and I do think that the hospital could play a role in that, again, assuming that we build it appropriately, and I do think that the outpatient provider could have a role in that, and incentivize both and hold both accountable for better follow-up after hospitalization or reducing readmission to the same level of care or higher. So I think there is a role for the hospital to make sure that that person connects to the next level of care. And if we incentivize kind of both sides of the aisle, I would think that would improve outcomes. And I saw improve retention and engagement and all of those things. I totally agree with that. But I think there's some that we could incentivize both parties to improve on.
I think the other thing, as I'm looking at these things, and then we can maybe come kind of wrap up the goals so we can have some time for some of the other, is some of these may be actually falling into some of the other categories around strategies. And so, you know, and it may require some rewording of these to make them fit the concept of goals of value-based payments. So I was just looking at a couple and thinking, oh, those are some of those are strategies that we might need to kind of look at. I think it was Gary Steck who said something about, I want to look at the chat for a second, about making sure we have family involvement and families as part of in the decision making, consumers being part of the decision making in terms of even looking at the goals of value-based payments, because ultimately, right, they're the people that it impacts the most, and whether it's access or outcomes, they're the people we're trying to create a system that's going to serve them the best.
Yeah,
So,
we need the child to be successful in that family unit.
Right.
I thinking about what you're talking about here, and I think it's important that we think about like all the players, and I don't see anybody from the school system involved in this, and I think they have a pretty significant impact on hospitalizations and just coordinating care, because if the school program is not in place for a kid, typically that's where we end up, and that's where the majority of our referrals come from, is the schools when school's in session. So I don't know how we integrate this in our goals, but I do think having a time and availability to coordinate care is one of the biggest challenges of the outpatient fee-for-service service model. There's, we're not reimbursed for all those extras that would provide proper care.
Can I ask a question about that? Hypothetically, if there was a care coordination payment and you had, I'm making this up, 50 kids attributed to your outpatient program, and those 50 kids are in XYZ elementary school or middle school. Theoretically, you could put a care coordinator in, assuming that the school was okay with that, you could put a care coordinator right in that school, right? Because chances are you're going to run into those kids on a daily basis if you plant that care coordinator right in the school. So one of the things, and this is maybe for a separate conversation, is like, what's the Medicaid payment authority that allows you to do care coordination outside of the four walls of the clinic, right? And so wanting to make sure we get those services out into the community, which I think somebody has already said.
So I can tell you, Bill, that in Pennsylvania, that's almost exactly what we had. So we had something called a CSBBH team, which is a community school-based behavioral health team, which was a value-based payment model. It was pay for performance, and that team was located right in a school. And so there was a very strong coordination. It was a private provider. It was my agency providing the service, but we worked closely with the school to be able to address a school-wide kind of from a school-wide perspective, the behavioral health needs in the school. And it required a close coordination between, at that point, the managed care company, the provider, and the school district to be able to make that successful.
And were those kids attributed to your provider, or was the school assigned, or you raised your hand and said, we'll take that school? Like, how were the kids attributed to you?
It was an RFP by the managed care company for 3 different school districts, and we just decided we were going to go for that particular school district because we already had relationships with the school district, and so we got the RFP, and then we set the team up in that school district.
Got it.
I also think we should acknowledge State Department of Ed and the tremendous amount of work that the educational, both at the district level and the state level, is attempting to do and get on top of this. It's a new area, student mental health, and but we've been a part of, DCF has been a part of a project with Department of Ed and 3 districts, the AWARE grant with CHDI and others, and there is a very strong model developed for school districts and school buildings. That's a completely integrated student mental health model, a three-tiered approach, coordinating school climate activities, social emotional learning activities, and identifying three tiers of kids of most need to the least need and universal. And they're learning a lot. The schools are learning a lot, but what is probably occurring as we speak in terms of transformation is the culture of their awareness really to recognize that if they're going to be successful at educating kids, they need to do a better job at identifying, referring, and tracking student mental health need. So we have a couple of activities going on that has some really promising practices. So on the inside, we have some of that, but one of the things we still are looking to do a lot better is to bridge the gap between the formal behavioral health system and the districts and the local schools. And many of you do that locally, and you have schools or school buildings or school districts that you'll do pieces of that with. And we're finding that they need a lot of assistance, particularly in data tracking, data, and being clear that if a student is identified as that they have a need that need is being met and they can demonstrate that. So Bill, any of those activities that encourage that also, again, would be really, really helpful in that area.
So looks like we've listed some additional strategies under the strategies box. And so maybe we want to, are there any other strategies that we want to think of? We talked about defining target populations, and it's another area. It's another strategy about within value-based is to make sure you're deciding who you're going to serve, and the high needs groups are typically the ones that are served, as a way of reducing emergency room visits, and higher levels of care.
I actually would like to add one more thing, and since I'm the note taker, I get to do it easily. But I would also like to kind of like plant in this group's mind the idea of pretty much in every setting that I talk with folks about, there's also the imperative to address social determinants of health. And it makes me wonder whether any value-based reimbursement approach might also contemplate incorporating flexible payments or some other way of allowing behavioral health providers, or maybe behavioral health providers in collaboration with care coordinators, to address various social determinants of health as major contributors to overall outcomes and well-being. So I can't say that I've got any further than that, but in my mind, I just think about whether there's an opportunity here for us to bridge not just behavioral health service delivery, but also the social services sector and addressing social determinants.
That is a tough one,
Yep.
Jeff. I don't know yet how to do this. I heard about, and again, this is not part of any of our models anywhere, but we were thinking for Inc. at one time, I'm just sharing this with you, we're not advancing this idea that if we could do a shared savings program with Inc. providers in New Haven, and voluntarily they would dedicate some percent of their shared savings dollars to a community reinvestment fund, that they would all have a member on the board, that those dollars then could be used for anything they want. But we determined that we as the Medicaid agency really couldn't ask providers to do that. But because I thought I heard about maybe in Philadelphia, kind of a community investment fund funded through shared savings dollars from Medicaid. But I agree, the social determinants of health are, that is a complex issue, and I don't know how to do that. The only thing I can think is if, and maybe again, this is fantasy thinking, that if the Medicaid payments are sufficient enough, grants can be redistributed to address directly social determinants of health. But I don't know. None of that is part of any model that we're advancing. Those are just kind of top of the head thoughts on how to deal with social determinants of health.
What
It's
we
a tough one.
One of the biggest determinants of health are adverse childhood experiences. And there's this whole adverse childhood experience scale, but even in adults, that also determines physical and emotional health. So I wonder if there could be some weighting towards, higher reimbursement with people with trauma, or better identifying trauma, or how trauma may be impacting, a child's presentation, to better, serve both the child and the adult population.
Trauma, see, that's a great example of something that's easier. So if we think, we can definitely include trauma screening, trauma-informed care. In fact, that is absolutely, that is part of the plan, is to make sure that everyone's doing trauma-informed care. And maybe there is a way to, stratify or risk stratify in some way based on a validated, ACE screening tool, that they would warrant a higher care coordination payment. So, those kinds of things are possible. It's when we get into housing and food and things like that, those get a little bit more difficult.
I think and I put it in the chat, and I see Bill, you agreed. I'm glad you did that. When we talk about goals of value-based payment, a simple goal should be to increase continuity of care with with a provider. And I think, to Dr. Wilson's point, trauma, it's also traumatic to constantly switch providers and not have that continuity, and it just doesn't happen elsewhere in medicine. You might see a specialist for something, but you still have your primary care provider. And even in psychiatry, I worked with individuals, with adults with trauma, who I might refer to a PTSD specialist for therapy, but I still remain involved as their general psychiatrist. But it seems with many of our child programs, that doesn't happen. You switch from one thing to another and constantly jump around. And I think a simple goal should be just to increase continuity of care with a provider.
I agree.
Right.
That's hugely important.
Especially in these kids with traumatic histories that have difficulties with attachment, and I think it all goes hand in hand. And the more attached somebody can get, appropriately attached somebody can get to a provider, I think the better outcome.
The retention of providers, though, is an issue. So you can have continuity with a provider organization, but retaining staff is at least in part a reflection of reimbursement and the ability to pay adequately in what, at least right now, is a ridiculously competitive market for the people who deliver most of the care, and that's master's prepared clinicians. And so a lot of these things track back to the reimbursement structure and rates. I would also add that in relationship to social determinants of health, having just come out of a meeting on housing, many of the providers that deliver services that are what we think of as sort of social service network providers, they don't have any capacity, or extra capacity. So we need to think about it in terms of how do you purchase that capacity and what would that look like?
Okay, maybe we should, after Jeff stops, after he finishes his typing, we should look at maybe and maybe spend a little bit of time on metrics and desired outcomes, and get some conversation going around those issues, because those are also critically important on who gets to develop the metrics and who says what's valued, and how that's framed for everybody in the system. So do we look at individual metrics? Is it family level, access, quality, And if it's quality, what does that mean? So definitions of metrics become really critically important when you're looking at systems like this. And who gets to define what is quality?
Maybe if we start with the actual member, we think about the member experience, which you have listed there. And how do we systematically and formally measure that? And Tim and I have been talking about measurement-based care and whether, well, I'd be interested to know what providers are doing today to measure member experience, and whether, as part of this process, should the state be thinking about standing up a kind of a federated portal that providers could use, specifically related to some, measurement-based care platforms that would capture member and family experience, along with lots of other data points, but member experience is clearly one of the data points that it would capture, and that providers could potentially use in-house, but then it could also potentially be reported up to our ASO to aggregate for the outcomes and the alternative payment model verification.
I'll just say this. The challenge in looking at member experience is the definition of member experience when you're talking about kids, right? So when you're asking about a member, if the member is the client and the client is 7 in an outpatient setting, really, are we talking about member experience? Are you talking about the family's perception of member experience? So I think about that. That's where I think some of the discussion about value-based payments and looking at metrics becomes tricky, because we're talking about children and youth. I mean, obviously, as you get older, you're better able to maybe measure member experience. But at 7, 8, 9, 9, 10, maybe even 10-year-old may not. And then what are you talking about when you're talking about kids who may have developmental delays and developmental disabilities? And how do you measure member experience with a child who has an autism spectrum disorder? And so I do think that's where the definitions and what we decide on are the appropriate measures for looking at outcomes and quality.
Yeah, this is Bert Plant. I would say that most of the measurement-based platforms that have child components to them do address that and consider taking in information from parents and other caregivers as well as the child. And so while I agree with you, it's a challenge, I think it's a solvable challenge. The other thing I would just comment with regard to measurement-based care is that it's really important, I think, and I may beat Heather to the punch in saying this, that it be able to be integrated with your EHR. So because the last thing providers need is another system that doesn't integrate with their EHR and is a standalone. So I think those are like sort of 2 critical components when we get to that point.
And to that, Bert, I totally agree with integration, but if everyone has a different EHR, then selecting one platform is going to be very, very
a number of the platforms will customize to the EHRs that providers are utilizing. So it's a challenge, but it's I believe a solvable one.
Yeah, I was just going to add the same thing, Bert. We've looked at a number one and looking at the different components of them, and that is a huge kind of basic requirement to be very fluid and flexible, to be able to connect with a large variety of EHR components. And it does begin, many of the EHRs are based in kind of the fee for service world, if you will, and a payment kind of structure versus, just being able to produce quality information around quality metrics rapidly. So there's a shift there that is really important.
There's also a comment in the chat box from Amber talking about the ability of an integration of measurement-based care from provider to provider. So we were talking earlier about provider continuity, but in instances where clients are being seen by more than one provider, the ability to share data, I think is what Amber is getting at here. Amber, anything to add? I know you added, there was another second comment you added. Do you want to jump in?
Yes, I will in a micro statement. So I need to jump to a patient, but I'll say also from the primary care setting to behavioral health care settings where many youth may be initially identified, or even from the school-based setting as someone I think put their thumb on, having opportunities for continuity of data such that providers are able to have access to that information, I think is important. And then I think measurement-based care also has cross-cutting implications for each of the domains that we've been discussing this afternoon, from some of the different goals that were identified around patient engagement and experience, improving quality and outcomes. And then I think also there's some really important conversation emerging in the NBC literature around how NBC might also help us to overcome some of the unnecessary care variability that we see in racial and ethnic minority populations and in populations that are much more vulnerable to social determinants of health. So just some other thoughts for consideration.
What's that? Did you say
I know
again?
we're at 2:58 and we have a 3 o'clock. So I want to be sensitive to that.
That's hard for.
Right, we got a little background noise from somebody, so if you wouldn't mind muting if you're not on right now. But yeah, Eric, we've got a couple minutes. Appreciate everybody's contributions here. I know this is just scratching the surface, but it's helpful to get this all out there. Tim, do you want to wrap up and close this out?
Yes, thanks again for a great conversation. We just want to continue. This was a great activity to kind of just walk through. And from my perspective, Bill, I'm not sure what your observation was, but it felt like for me, a lot of the comments that were made were really aligned with some of the internal conversations that the state partners were having in preparation for a few of these different projects. So that was really nice. I like the structure of just articulating the kind of the goals and the things that people are missing. So we'll get this information out to everybody, and we'll ask folks, feel free to weigh in electronically in between meetings. The next meeting here is August 25th, and then meeting after that is September 22nd. So the next two meetings. And so we're down 1/3 with these two meetings. And again, we may have to reconstitute or continue on beyond Thanksgiving, but at least this initial first 6 meetings was really structured around these activities. So we appreciate everybody's involvement, and continue to invite somebody to think about joining us kind of as a facilitator of the work group. And we'll make sure that the information gets put forward in a formal recommendation, and we'll make sure we bring that back to this group. So thank you, everybody.
Can I just say one thing? Amber did remind us of something that's really critical that we haven't said out loud from the state perspective, is that everything we're talking about, access, outcomes, everything has a health equity lens to it. Everything we do has to have that lens, kind of overarching everything that we're talking about.
Yes, agree. Great.
Thank you,
All right.
everyone.
Thanks, everybody.
Thank you.
Have a great day. Great afternoon.